there was a point in time where all the striving was just to make an impact, just to help patients overcome suffering, live longer. We're now at a point where we have cures, we have diseases which converted to chronic disease, we have therapies that can be administered with much less suffering. And I think you get to a point where, as we did, as a specific disease, testicular cancer, we can say maybe we don't need 6 cycles. Maybe we can actually give 4 or give 3. And I think in a way that value story maybe is an evolution that it was almost impossible to go down that road when all you're doing is striving for some improvement in suffering people. Now maybe we've gotten to a point where there's enough improvement that we can start to look at this. But now we're at a point where you look at the NCCN guidelines and you see 16 different regimens listed for node positive, HER2 negative breast cancer. And you've got to ask yourself, can that much variance be a good thing? So Ira, you've lived for years on that payer side, and now you're on the pharma side, and it's a learning piece for you. You're understanding maybe a new perspective, but the variance piece has got to be something which is provocative to say that something needs to be done.
Yeah, I think what I think of when I think about value in the pharmaceutical industry, I think of, can we define what we're talking about? I work in the brand space, so innovative medicines that come from preclinical through phase 1, 2, and 3 to FDA approval, then post-market surveillance after that. So, there's value on the generic side, but I'm not an expert on that. All I can say is that if you look at other disease states and population health, for example, if you look at cardiovascular disease, death rates have gone down by half in the past 20 years, and the therapy is pennies per day. So we tend to forget about that. But working in the brand space, I think of parsing this between what about introducing a new drug in a therapeutic class where there are multiple other drugs, and are we doing a lot for society there, versus trying to explore new mechanisms or greatly improved mechanisms of managing disease to get to what you said before, which is cure or amelioration of disease and the ability to translate that disease into a chronic disease. So, I kind of look at now how brand companies can think about putting drugs into the innovative space. And there's some issues there because we're talking about now, as Mike said, a point where we want to investigate this. So are we going to investigate this using the tools we've used in the past? And the tools we've used in the past are the ones that have been handed to us really by the FDA, looking at safety and efficacy. And so the tools of overall survival, progression-free survival, time to progression, those things sometimes work, but in breakthrough drugs may not be so accurate. And then there's some surrogate measures that just don't work at all. So I think we have to get better at the tools. What are the rulers? Because I would argue that in breakthrough treatments, sometimes we don't have overall survival data because the drug is too good and it's too far in the future. So that's a good problem to have, but it's a tough problem as we wrestle with the overall problem of the cost of drugs and how that nests within the total cost of care, as Ted said. We just don't have a lot of data. The other thing is we don't have a lot of great data exchange. I do think that this new paradigm that Mike talked about will hopefully include people being not just transparent about some aspects of how they do their business, but transparent about sharing the data. Because we've got data that's locked up in multiple vaults that I think is not benefiting society because we're not sharing it. And that is a way to reduce costs.